Hello everyone. In this video, we are going to have a quick recap of our knowledge in calcium channel blockers. We focus on its classification. Alright, as we know, we can classify calcium channel blockers, or we call CCBs, into three groups. Group 1, selective L-type calcium channel blockers. Group 2, selective other types of calcium channel blockers. And Group 3, non-selective calcium channel blockers. Moving on to the group 1, selective L-type calcium channel blockers. These L-type calcium channels are voltage gated and long lasting, referring to the length of activation. They are responsible for many functions. What we need for today's discussion is excitation, contraction, coupling of cardiac muscles and smooth muscles in blood vessels. In cardiac myocytes, these L-type calcium channels passes inward calcium current, and it triggers the release of calcium from sarcoplasmic reticulum inside the cell. I'll show you how it works. This is the cell membrane, and this is the protein calcium channel, and this is how the inward calcium current flows inside into the cell. What happened is when a stimulus came, this protein channel will open, and just like this, a calcium ion flow, we call a calcium current, will influx into the cells. With the increase of that in calcium ions inside the cell, sarcoplasmic reticulum channels will open and flush calciums into the cell from sarcoplasmic reticulum. Then our required function, excitation, contraction, coupling of cardiac myocytes, and smooth muscle cells will occur respectively. That's how calcium channels contribute for our required function today. Let's move to the classification. Group 1, they are selective L-type calcium channel blockers. Further, we can classify them into Group 1A, Group 1B, Group 1C. Group 1A are dihydropyridines or DHP. Group 1B are benzothiazepines. Group 1C are phenylalkylamines. Some literature classify these calcium channel blockers just like dihydropyridines and non-dihydropyridines. So other than dihydropyridines, all the others in the group 1 and group 2, group 3 are non-dihydropyridines. But this is how I learned, and this is easy to remember. So I think it's best. About group 1A dihydropyridines, their selectivity for smooth muscle cells in arteries, in vessels, is high than cardiomyocytes. Going down in this list, 1B, 1C, the selectivity changes. In group 1B, almost same selectivity between arterial smooth muscle cells and cardiomyocytes. In group 1C, it's mostly acting on cardiomyocytes. So examples for group 1A dihydropyridines, I can give nifedipine, nimodipine, clebadipine, like dipines, suffix dipines. Group 1B, I can give diltiazem. We call that this 1B class as intermediate class because they have almost same selectivity for arteries and heart. And 1C, as I told you, it's mainly acting on heart, negative inotropic effect, verapamil. When talking about negative inotrope, we always come up with verapamil because this is the reason. I will tell you about these inotropes and chronotropes. Inotropes act on cardiomyocytes and reduce its contraction ability. That's what we need in this. There are some calcium channel blockers that act as chronotropes. What are chronotropes? Chronotropes will reduce the conduction in conduction system, SA node and conduction system. There are some types of calcium channel blockers like mibrafadil, I will tell you in future. They mainly act as chronotrophs. So moving on to the group 2, selective other types of calcium channel blockers. There are several types. I selected only 3. N-type, example, cigaretoid, conotoxin, it's a conotoxin, and they block N-type calcium channel blockers mainly. P-type spider-toxins, they block P-type calcium channel blockers. And alpha-2 delta channel blockers, mainly we are using gabapentin. There are other types of calcium channel blockers in wide range of activities. These calcium channel blockers not only acting on cardiomyocytes and smooth muscle cells, they are acting on brain, they are acting on skeletal muscles, like gabapentin on brain, like that. So there are other types as well. And there are non-selective, group 3, calcium channel blockers. Phenylamine is not used now. This was used as an antihypertensive drug in past, but because of its QT prolongations and causing torsades point and causing sudden death, we are not using this drug now. And flunarizine we still use for migraine, prophylaxis of migraine, and as also as an adjuvant therapy for epilepsy. This is the drug that I told you about. This was mibrafadil. This drug was introduced as a selective T-type calcium channel blockers that accounts for the group 2. But later, after about 10 months, in a very short period, they identified that this is non-selective, also not only acting on short-lasting T calcium gates, they also act on long-lasting L-type calcium channels, and also they give some deadly adverse effects. So now not used. Actually, they are non-selective because they both act on T and L. Further, we can classify this dihydropyridinese in group 1A into generations. First generation nifedipine, second generation felodipine, third generation amlodipine, like that. So that's all about the classification of calcium channel blockers. I hope you remember.